Welcome to the inaugural episode of Our Path Forward, a new webinar series featuring topical conversations tackling today's most pressing public health problems. I'm Ron Brookmeyer, Dean of the UCLA Fielding School of Public Health. This year, our school is celebrating its 60th anniversary, 6 decades of impact. Dialogues like the one we're having today bring light to our most critical public health challenges and what we can do about them going forward. Today's conversation is on addressing the Alzheimer's epidemic, and we're fortunate to have two outstanding experts joining us. Before we dive in, a couple of notes. The webinar is being recorded and will be available for viewing soon on the UCLA Fielding School's YouTube channel. If you'd like to ask a question, please use the Q&A button at the bottom of your screen. You can type your question at any point during the hour, and we'll try to get to as many as possible in the last segment. We've come together today to talk about Alzheimer's disease. Well over 6 million Americans are living with full-blown Alzheimer's or have early signs of the disease. That number will more than double in the coming 40 years. The devastating disease takes a terrible toll on the lives of patients, their families, and friends. We are all touched in some way by this horrible disease, whether it be an afflicted family member, friend, or colleague. It's an attack on the mind, on one's identity, on one's self-determination. Caregiving costs are enormous, whether formal care such as nursing homes or informal care, the devoted work of spouses and adult children. For many families, there is little support or relief. Development of effective treatments has been frustratingly slow. There are few FDA-approved treatments and their effectiveness is modest. But there are also some optimistic signs. We now have a better understanding of how the disease develops and its causes, and that understanding could ultimately lead to development of better treatments. And recently, there have been some discoveries of new biomarkers detectable by certain brain scans or even blood tests that may signal the beginning of the disease, allowing the possibility of early intervention before the disease gets too advanced and fully ravages the brain, before it's too late to do anything about it. I'm so pleased that we have with us two extraordinary experts to discuss all of this. First, we have Dr. Claudia Kawas, a geriatric neurologist who is the Al and Trish Nichols Chair in Clinical Neuroscience and Professor of Neurobiology and Behavior and Neurology at the University of California, Irvine. Dr. Kawas was awarded the American Academy of Neurology's Potemkin Prize for her pioneering dementia work, sometimes referred to as the Nobel Prize of Alzheimer's Research. The award is an internationally recognized tribute to those advancing our understanding of dementia. Let me just say, I've had the good fortune to know and collaborate with Dr. Claudia Kawas over the years. Thank you so much, Claudia, for being here with us today. With us today, we also have Dr. Elizabeth Rose Mayeda, a terrific faculty member here at the UCLA Fielding School of Public Health in the Department of Epidemiology, who is doing groundbreaking work to understand cognitive decline and the disparities that exist in how the disease is distributed across populations. I've also had the good fortune to collaborate with Elizabeth Rose on Alzheimer's and dementia research. Thank you so much, Elizabeth Rose, for being here today. Okay, let's get started. Claudia, let me turn to you. There are many types of dementia. Not all of it is Alzheimer's. How difficult is it to diagnose Alzheimer's, and can you differentiate it from other types of dementia?
Well, the first answer is that the longer I do it, the less able I feel to do it. The more I know, the harder it becomes. So let's start with what is dementia. Dementia is the loss of cognitive abilities like memory or language or calculations from a previous level that's severe enough to affect your ability to do your day-to-day things, occupational and social functioning. And there are more than 100 different causes for dementia, of which we've been told the most common in old age is Alzheimer's disease. Alzheimer's is definitely common, but there are a lot of causes of dementia. And for the most part, I don't have a test that'll tell me, first of all, other than checking your memory and cognitive abilities to find out if you have loss. I do that mostly with neuropsychological tests or mental status instruments. But then I don't have a test that'll tell me for sure whether or not what's causing it. Having said that, over the last couple of decades, though, we've had enormous strides, and probably the largest of them is during my career, we became able to tell if you have one of the most the definitive hallmark of Alzheimer's disease in your brain, and that's whether or not you have amyloid plaques. When I started, we could only do that at autopsy, and so we only knew for sure. Now we can do it with PET scans, for example, and there's increasing work on detecting it using blood biomarkers and other kinds of samples. They don't tell you for sure the answer, though, that the problem is caused by Alzheimer's disease, but they certainly help increase the likelihood.
And there's this construct called mild cognitive impairment. How does that relate to Alzheimer's? And can you tell the difference between mild cognitive impairment and Alzheimer's?
So actually, what you should be contrasting is the difference between mild cognitive impairment and dementia. And the original description of mild cognitive impairment was individuals who had a memory problem, and that was defined as being about a standard deviation and a half below what we would expect for your age. And then the definition got broadened to having almost any cognitive problem, but is still below what you would expect for your age. But you don't meet the full-blown criteria for dementia. So you have a memory problem, perhaps, but most of your other cognitive abilities are fine. And your ability to do most of the things you want to do around your house or your job are still fine. You might be writing lists or whatever because your memory is bad, but you can still function. To many people, having a profound memory problem or any other cognitive problem, even if it doesn't meet the criteria for dementia, without question increases your likelihood of in the next few years having dementia. And it seems to increase in particularly your likelihood of getting the diagnosis for your dementia of Alzheimer's disease. So it might be a gateway to that because it increases your risk. But even if you have mild cognitive impairment, you don't necessarily progress, and you also don't necessarily turn out to have Alzheimer's disease.
So let's talk about risk. And Elizabeth Rose, let me turn to you because not everyone gets Alzheimer's, and some get it much later if they get it at all. What do we know about the risk factors and who's more likely to get it than not?
Yeah, so I think age is a major factor. So most people with dementia are older adults, so over the age of 65, but particularly over the age of 80. Gender is also another factor. There are more women than men living with dementia, but we think that's mostly due to differences in life expectancy by gender. And if we look across racial and ethnic groups, it gets very complicated. But some racial and ethnic groups bear a disproportionate burden of Alzheimer's and related dementias. And in particular, Black Americans have about 1.5 to 2 times higher risk of dementia than white Americans.
Why do we see racial differences? What would be the explanation for that?
Yeah, there's a lot to unpack there, but one thing I want to emphasize is that we don't think this is due to genetics. Race is a social construct, and there's a very incredibly complicated web of historical and contemporary systems of privilege and oppression that produce disparities in health, including disparities in brain health and aging, so Alzheimer's and dementia.
Mm-hmm. You know, there is some genetic factors. I mean, with apolipoprotein, the E4, what do we know about any kind of genetic component to Alzheimer's? Claudia or Elizabeth Rose on that?
I'll start.
Oh, go ahead.
Start with the strongest genetic susceptibility factors, which was discovered decades ago, actually, is apolipoprotein E. Apolipoprotein is a normal thing. It's like blood type. It comes in different flavors, 2, 3, and 4 instead of A, B, and O. And you inherit one of them from each of your parents. And if you inherit an E4 allele, or even worse, 2 of them, you definitely have increased risk of developing amyloid-related Alzheimer's disease, especially if you're white. The risk of ApoE varies by ethnicity. It also varies in different parts of the world, but it is the strongest genetic susceptibility factor. Having said that, I need to say that I've studied a lot of people who made it to age 95 with 2 E4s and did not develop dementia.
There are, in terms of other risk factors, and one was mentioned already, which is testing for amyloid plaques. And there seems to be some good data that if you're positive for amyloid plaques in the brain, you're at higher risk. Is that true? Do you agree with it? And if so, do you think people should be routinely screened for amyloid?
I can start with this one. So I think that these new biomarkers, so including brain scans and blood tests to identify people with amyloid, it's really useful from a research perspective because, as Claudia mentioned, dementia is a syndrome and there's lots of different underlying brain pathologies. So if we're trying to identify the causes and potential treatments for dementia, it's helpful to think about causes and treatments for specific etiologies, and I think the biomarkers are useful there. But I really don't think it's ready for clinical care for 2 reasons. One, many people who are positive for amyloid based on biomarkers will never go on to develop dementia. And 2, we currently don't have effective treatments to recommend for people who are amyloid positive to modify their risk of getting dementia. So while I think it's very useful for a research perspective and maybe someday will be useful clinically, I don't think it's ready for clinical practice right now.
Claudia, do you agree?
Completely. I mean, to me, one of the most profound accomplishments of the last few decades was being able to detect amyloid in the brain of people while they're still alive instead of when they biopsy. And it has been tremendously helpful in helping us understand things. But having said that, the majority of my patients, I'm not interested in doing it clinically, especially since amyloid positivity is less and less predictive with age. And because I know that you can be amyloid positive on a scan for 15 or more years before you develop any symptoms. And mostly because right now, except in the context of research and particularly research of amyloid related type drugs, it doesn't help me at all to know whether or not somebody's got amyloid positivity in their brain yet.
So, let's turn to the question of caring and managing care for Alzheimer's patients. We don't have that many effective drugs. Claudia, from your perspective, how do you manage the care, the symptoms of patients, given that we don't have very many drugs that are really disease modifying?
Yeah. So the first thing I think we need to do is not forget the things that maybe don't cure this disorder, but definitely help everybody, the patient and their family often. And one of those things is to do the best job I can to make a diagnosis and to give them as good an idea as I am able to of what to expect. That's hard. Some people stay the same for a long period of time and don't decline at all. And some people decline very rapidly and some people bounce around. But I think telling the families and the patient what the diagnosis is, and in my opinion, and giving them an idea of what to expect, providing education and safety measures that, might be very important, if not now, and then in the near future. The next step for me is treating the treatable. So most people who have this, whether it's in reaction or part of the disease, very frequently have depression. In some cases, they have other psychiatric symptoms, anxiety, even sometimes delusions or hallucinations. And many of those things, we do have drugs that work very effectively. And I think I help more patients with some of those drugs than I do generally with the drugs which I also use to treat the cognitive loss. Those drugs primarily consist of the anticholinergic drugs. They were the first to be approved by the FDA many years ago. Their effect size is not huge, but some patients are helped much more than others. And I think pretty much the majority of patients to my clinic will try one or more of those drugs to see if we can benefit them that way. I like talking to people about participation in research. It takes a village to figure all this out. The patients and their caregivers are really a big part of what we need to work all this out. And so I also talk to them about opportunities to participate either in observational research or clinical trials or any other things.
So speaking about, you mentioned the FDA and drugs, there was some controversy last year over the FDA approval of a new Alzheimer's drug, aducanumab. There were some really questions about the drug's overall clinical effectiveness, although it did seem to dissolve the amyloid plaques in the brain. And I guess I'd like to ask, both of you, should the FDA be approving drugs that have marginal clinical benefit, although they seem to reduce, the biomarkers? I don't know, Elizabeth, Rose, what's your take on that?
Yeah, I'll start, and I'll add that this is definitely a controversial topic. So depending on who you ask, you'll get a different answer. But from my perspective, what we really care about is treating the symptoms. So treating cognitive symptoms. And I personally think FDA approval should be based on drugs that show they provide clinical benefit and improve people's quality of life. And I guess I'll add, I think we also want to weigh the benefits against potential harms. And there was some evidence that aducanumab also, there were about a third of people had some evidence of micro brain bleeds and brain swelling. So I think we want to take into consideration potential clinical benefit and as well as potential harm.
Now, I'll just add that, what you're really saying is, should the FDA ever approve a drug that moves a biomarker, essentially, but doesn't necessarily demonstrate during the course of the studies clinical benefit? And that's the essence of the accelerated approval process, which isn't typically used for very many drugs. The majority of drugs in this country have to go through efficacy and safety profiles and get full approval. In the accelerated process, it's approved on the basis of a biomarker that at least one has to believe has a reasonable chance of predicting the outcome. And that's how this got approved. There were drugs before aducanumab that moved the amyloid biomarker, for example, solanezumab and almost all of the anti-antibodies. The problem has been whether or not that goes along with clinical benefit. And depending on the controversial part, I guess, is how one would interpret what limited data was available for aducanumab. Aducanumab, despite its accelerated approval, actually, the data came exclusively from 2 trials, which were both terminated prematurely for futility. And then somehow that turned into the idea that one of the 2 trials, not both, did maybe show some clinical signal. The other one definitely did not. So I'd say, I agree. We didn't get too much controversy between me and Elizabeth, because I'd say we both kind of agree here that the clinical benefit is not yet clear, while the safety profile we know quite a bit about. I'll add too, though, that there are other drugs in the same rough category that are coming through the pipeline that, who knows, maybe will do more than just move the biomarker during the trials, but that's still a work in progress.
So, with drugs where progress is slow, and amyloid is one target. But let's turn now not to the therapeutic question, but let's turn to prevention. And according to one study, it's suggested about 30% of lifetime risk of developing dementia can actually is caused by things that people can do something about, prevention. And so I wonder what your take is on the evidence for prevention for lifestyle factors that can reduce risk or delay onset. And what are they? What are the most important ones? So I don't know, Elizabeth, Rose, you want to take the lead on that one?
Yeah, I'll start. So I guess I'll say that the evidence isn't equally strong for all of these modifiable risk and protective factors, but I think overall, I think the evidence it's good news that we think there are things people can do to prevent Alzheimer's and related dementias, like maintaining a healthy blood pressure control in midlife, preventing or managing diabetes, and then from a more population perspective, making sure that people have access to formal education, which is very, very consistently linked with lower dementia risk. And I think education is particularly interesting because we think it might impact or lower your risk of dementia by helping you live a healthier lifestyle. But also we think it might help build cognitive reserve, which means we think it can help people maintain function or prevent onset of clinical symptoms despite brain pathology. So that includes things like Alzheimer's. Other modifiable risk factors cited in the review include things like hearing loss, maintaining a healthy weight in midlife, quitting smoking, preventing and managing depression, staying physically active. And I think a really interesting one is staying socially engaged. I think that's a really interesting one that I'm sort of excited about the potential for further research about to understand better.
Claudia, you have an internationally recognized study, which is the 90+ study, which looks at 90-year-olds and correlates it with their risk factors and lifestyle factors before. And I was wondering what have you learned from that study with regard to lifestyle and longevity and dementia and healthy aging?
Well, I guess the first thing I would say I've learned is that age matters. I mean, I really believe that all along, which is why we started the study. But I mean, certainly a lot of our data and things, which I'll tell you about in a minute. I mean, one of the clear things is that it's not just whether or not you have an ApoE, but at what age I'm looking at your risk of ApoE, for example. So for starters, ApoE4, which is the strongest genetic susceptibility factor that we have, we just talked about. If you reach age 90 and you have an E4 or even 2 E4 alleles, it does not increase your risk of dementia. E4 is a genetic susceptibility factor. Its effects appear to happen at earlier ages, and by the time you're 90, it doesn't matter. In contrast, education, which happens in the first 20 years of your life, at least the way we're measuring it, always seems to matter. So even among our 90-year-olds, higher educated individuals have a lower risk of dementia compared to lower educated individuals. And worldwide, I mean, in terms of preventing dementia, maybe not in the United States, but worldwide, that appears to be a really modifiable factor that could have incredible effects for sure. I think some of the things that have surprised people the most about what we've learned in terms of age matters again is that while high blood pressure in midlife, high cholesterol in midlife have been associated with increased risk in late life of dementia. And we also seem to see in our data sets that if you develop high blood pressure when you're 60 and you get it treated, that you reduce or eliminate most of that increased risk. But what we see is if you get a diagnosis of high blood pressure and you're in your late 80s or 90s, you actually have a reduced risk of all-cause dementia compared to individuals who never even develop hypertension in their entire life at the same age. So high blood pressure actually appears to be protective in your late 80s and 90s, and we're working on why that may be. At this point, it's been replicated in several data sets, so I'm quite convinced that it's good to get a diagnosis of high blood pressure in your 80s and 90s. What I need to figure out next is whether or not we should be aggressively controlling blood pressure in these individuals. The idea being that maybe when you're 90, you need that pressure for more perfusion or other ways that will maintain brain health. We have a similar effect, by the way, with high cholesterol. Here we can't tell, we don't have the right data to tell if it matters what age, but if you have high cholesterol, and most of these people are treated with statins, you actually appear to have a lower risk compared to individuals in their 90s who do not report high cholesterol and are not generally taking any cholesterol-related medications. So age matters. What's good or bad at young or midlife is not necessarily what's good or bad to maintain the best health and lower risk of dementia in late life.
So following up on that, and we're talking about education, and certainly education early in life builds up cognitive reserves. And Elizabeth Rose, you mentioned social engagement as well. How important are those things later in life? If you don't use it, you lose it. I've heard that expression before. Does education, staying engaged socially, crossword puzzles, those kinds of things, can they help?
I think they certainly can't hurt. I think one of the things, I think a lot of these, the use it or lose it hypothesis and social engagement is part of that. I think it fits in with this idea of potentially building cognitive reserve. And so I think that there might be sort of a natural inclination for people as they begin to experience maybe some cognitive loss to sort of retract socially. But I think we think that actually remaining socially engaged and cognitively engaged in activities, it really might be protective and might help people continue to function a little bit better, even if they have brain pathology. And I guess, Claudia, do you have anything to add about that? I think this is one of the things that seems to persist, I think, that doesn't quite vary with age, as you mentioned, for education. But I think as well for other cognitively stimulating or socially engaging activities.
Yeah, and I think we underestimate how much brain power or whatever you're using to engage with other individuals. Excuse me, we talk all the time about crossword puzzles. There's nothing wrong with a crossword puzzle, right? But on the other hand, I personally think that if you do 1,000 crossword puzzles, and you get very good at them and you know all the words and everything, I'm not sure how much you're using your brain to learn how to do crossword puzzles or learn how to do 5 other different new puzzles or something. I think it's probably more engaging. I also think that when we're talking to individuals and engaging ourselves in any kind of social thing, we underestimate how much that has to marshal our brain resources. And yeah, to me, the brain is just like muscles. I mean, use them or lose them. If you weight lift, you have different muscles than if you walk around only, and both of you have different muscles than the person who stays in bed all the day. So I think withdrawal from social interactions actually is not good. And in our study, we looked at these factors in relationship to longevity. And in relation to longevity, what we found is exercise 15 minutes a day reduced mortality, 30 minutes was better, 45 minutes was the best, 3 hours or more, whatever, it didn't matter. You know, you got maximum benefit at 45 minutes. But then when we looked at non-physical activities, and here we put everything, including crossword puzzles, including going to concerts, including museums, anything that they mentioned, that never leveled off. We took that out to 8 hours. And with every additional hour that people in their 70s were reporting activities, the longer they lived compared to people their same age. So I think that those kinds of things encompass both cognitive and social exercise of a sort. I think they're important for longevity. The evidence for avoiding dementia is a little less clear to me, but I still think get out there and interact with people is an important thing when you age.
You know, as you were speaking about this, I was thinking about the pandemic and what we've all been through, and the elderly have been through, and how isolating it has been, and the physical and social distancing. And, you know, we don't know what the long-term effects of that will be. And it makes me wonder.
Oh, and here I'm very concerned for all ages. I mean, we all of us who work in geriatric care, you know, definitely seen the toll it has taken. I mean, in all ways on the elderly, but also I'm worried about the youngsters who are going through a lot of their development period in this very isolating kind of time.
So, you know, the numbers are staggering, as, you know, we're an aging society, and now we are facing an epidemic of dementia, of Alzheimer's in particular. So let's come back full circle now to the way forward. What do we do as a society in public health? What does the government do? What policies do we need? What are our priorities, whether it's in research or where should we be putting our dollars? How do we begin to address this staggering problem? Elizabeth, Rose, do you want to start off on that?
Yeah, I think one of the ways one of the things I want to start thinking about is how we can improve the lives of patients and caregivers. So a lot of us as public health researchers are really focused on prevention. And I think that's so important, but I think we can't leave out thinking about what can we do now to improve the lives of people living with dementia and their caregivers. And so I think that can include things like making sure that patients and caregivers know what to expect when somebody receives a diagnosis of dementia, like Claudia mentioned, and making sure they understand what resources are available to them in the immediate and long term to help them make decisions about how to care for their loved ones as their symptoms progress, and expanding those support services. So support services I'm thinking about include things like access to social workers and geriatric case managers that can help caregivers understand what resources are available to them and how to access them. So this includes things like home health services, assistance with everyday activities in the home, like cooking, cleaning, laundry, adult daycare centers, I think support groups for caregivers and people with dementia. And then I think also making decisions and understanding options for long-term residential care or in-home care as well.
I so agree with that. I mean, I think that, you know, all the time now, right now, there's a strike going on at our institutions, and it includes the issue of childcare. But I think senior care is something we need to give some attention to. It is, our current burden is going to quadruple by the middle of the century. It is a huge problem. It affects not only the health of the patients who are coping with this disease, but all of their loved ones and their caregivers. And I think we really need to give as much attention as we can to helping them until we find some other more efficacious approach, for sure.
And I'll say one thing that really got me thinking is with one of the controversies with the aducanumab drug was that the original price tag, I think, was $56,000 a year annually. It came down to, I think, around $28,000. I thought, what could we do? What could we do with that amount of money just directly going into supportive services for people living with dementia? And so I think that's just something for us to keep in mind when we're thinking about allocation of resources and funding, is not forgetting potential expansion of resources that could immediately impact the lives of people with dementia and the people who care and love for them.
Yeah, and I think your point about it being helping immediately, because some of the other things that we're doing in research are going to take a much longer time horizon. Is research going in the right direction? I mean, we've been targeting this amyloid, and the drugs have been, we haven't hit the home run yet. Is that the right direction that the therapeutics and should be moving?
Well, I think that's the direction it's mostly moved. I mean, in large measure over the last few decades. I think there's been a lot of progress there in both detecting amyloid and now removing amyloid, and we're still waiting to see to what extent that's going to improve cognition. And it remains an important area of research. But I think that in the last couple of years, I've seen the field opening up to the possibility that even in Alzheimer patients, that other targets or different targets might be relevant. Or everybody likes the model of the cocktail like we use in cancer, where, okay, you'll take one drug for amyloid, one for tau, and one for good luck or something. And it might be that that'll be a productive way to look at it. But I also want to bring forward what I think we're more appreciative of now than we were before. Alzheimer's disease definitely is the most common pathology we find in our 90-year-olds or any demented populations, actually. But in fact, analyses recently, for example, from the extensive Rush data set, unpublished data in our own 90+ study shows us that it may be the most common single disorder, if it is a single disorder, but it still only accounts for only about 25% of the attributable risk of dementia. So I think the other thing that hopefully is going to be growing over the next few years is actually looking at those disorders, which currently, for the most part, we cannot diagnose during life. Just like 40 years ago, we couldn't detect amyloid. We cannot detect, for example, TDP in the brains of individuals during life. And yet in the 90-year-olds, that accounts for almost as much dementia as Alzheimer's disease. And that disorder has recently been dubbed late, limbic predominant, age-related, TDP-43 encephalopathy. It's somewhat controversial because it does occur, co-occur with Alzheimer's disease, but it also occurs in the absence of Alzheimer's disease. And it is also related to a large chunk of dementia. And finally, and most importantly, in the 90+ study, where Alzheimer's disease and late are down in the 20% range, if you put all the vascular things together, the hardening of the arteries, as well as the infarcts, large and small, it's actually 40% of the attributable risk of dementia. So I think it's time to also go back to the old hardening of the artery stories and try to better understand the vascular contributions, because even among people with AD pathology in their head, they are more likely to have dementia if they also have vascular. And more than 50% of people who come to autopsy with Alzheimer's disease have that vascular. So we need to understand how that's contributing to the expression of Alzheimer's disease and dementia, because I think it's another area where we have a target we can work on. One of the things I'll mention, I didn't believe this data at first, but now I'm pretty convinced, but Elizabeth's the expert on this. But several data sets have suggested that over the last 20 years or so, the incidence of dementia, the age-specific incidence of dementia, has actually gone down. And that's an intriguing finding. And what would be causing that is even more intriguing, right? And the good news is the only thing I know for sure is it was not caused by an amyloid antibody after screening, with a test, right? So the question is, why is the age-specific incidence going down? And I think that what you're really seeing there are some of the things that Elizabeth mentioned, which is improved vascular management of risk factors like hypertension, diabetes. I think worldwide, there's been some improvement, especially in certain areas of education. So it's got to be some of those things if the decline is real that has happened. And I think that's very encouraging news too.
Yeah, what's good for the heart is good for the brain, and you're absolutely right that the age-specific, and just so there's no confusion, the age-specific incidence is going down, but still the overall numbers of the number of people who are going to get Alzheimer's is drastically increasing, and that's because of the aging of the population. So those are two facts that important to keep straight. But you're right, the overall management through cardiovascular health seems to be partially responsible for the decrease in the age-specific incidence rates of dementia. We have a whole bunch of questions coming in from our audience. I don't even know where to start, but so let me just start at the first one that I see here is about nutrition and diet. What do we know from research and literature about the role that nutrition and diet can play in protecting you from Alzheimer's, or at least delaying its onset?
I don't think there's a magic bullet, like, eat this one food or don't eat this one food. But I think as you mentioned, Ron, with the themes of things that seem to be risk or protective factors, what's good for the heart is good for the brain, as you said. And so we think that the same sort of lifestyle and diet, including dietary factors that are good that we think of as being good for your heart health, are probably good for brain health. And I guess I'll also add, we've been talking about lifestyle factors, and I just want to mention, I think from a public health perspective, we always want to keep in mind that individuals' lifestyle factors are shaped by the environments in which they live. So we can be thinking as public health professionals, what we can do to help people live healthier lives, as well as educating people so they can make those healthful decisions as well.
What about a glass of wine? Is that helpful or harmful?
So I'll say in the 90+ study, individuals who reported drinking occasional alcohol, like that one glass of wine, and didn't have to be daily, by the way, it could be like once a week, lived longer than individuals who reported drinking no alcohol at all. That was also true, by the way, of individuals who reported caffeine in the range of 200 to 400 milligrams a day, which is 1 to 2 cups of coffee, basically, compared to individuals who did not have any caffeine, whether it be from whatever source, actually. So I think those things, and they've been reported in a lot of places, are definitely associated with longevity. It's often been called the French paradox or things like that. Whether or not they affect your risk of dementia, if you're talking about moderation, is not so clear to me.
Yeah, I think that the evidence isn't strong either way to avoid or encourage drinking alcohol in moderation, caffeine, simply for prevention of dementia. So I guess I'd say you could make your decision about whether to have a glass of wine with dinner based on other factors, maybe.
Now, I'll also mention supplements, right? Because a lot of people, rather than eating their vegetables, want to pop a bunch of pills and all kinds of vitamins and nutraceuticals and what all. And in our hands, for example, where wine was, or any other alcohol in moderation, was associated with longevity, as was caffeine, vitamin E supplementation, vitamin C, vitamin A levels and supplementation, all of the pills that we could check, we had modest data, were not related to longevity or to dementia, right? So I think if you really want to do it, I want to emphasize something Elizabeth said. It is not one thing. Everybody wants me to say, oh, eat blueberries or whatever it is. It's not. A good diet matters, but it is not ever. In fact, I personally have always said we should put a variety variable into our diet studies, because in some ways, I think that the people with the most variety in their data, in their diet, heavy on fruits and vegetables and plants and seafood over large amounts of meat and all those kinds of things. I think that people have a good diet. It's good for the heart and it ends up being good for the head for sure. But it's not just eating blueberries or just eating a vitamin pill or whatever, at least not yet.
So I've heard a couple of words here. I've heard variety. I also heard moderation. I remember a high school teacher once said to me, everything in moderation. But there is one question here on the drinking about on alcohol, about the impact of heavy drinking, not moderate drinking, but heavy drinking on Alzheimer's or dementia risk. Do we know anything about that?
So I think it doesn't affect directly your Alzheimer's risk if Alzheimer's is the development of plaques and tangles in your brain and the thing we diagnose under the microscope. I think it very definitely affects your overall brain and neuronal health. And it even more affects your peripheral nervous system. So we know that heavy chronic alcohol is one of the more common causes of peripheral neuropathies. We know that heavy alcohol is also associated more with head trauma and bleeds because blood, gets thinner and you fall more often. We know that it is associated with problems in the midline part of the cerebellum in particular, which is why after people who drink a lot often have gait disturbances and their balance isn't as good as everyone else's. So it definitely affects brain health. And at the end of the day, I think whether or not you express memory loss in the presence of things like Alzheimer's disease has a lot to do with your underlying brain health. What we find at autopsy, for example, is individuals who have a ton of Alzheimer's disease in their head and yet remain normal. They always have healthier brains. They were first reported 20 years ago to have heavier brains. They have less atrophy. They have less other kinds of damage. So in that sense, it is not good for your brain and your dementia, for sure, to get carried away with alcohol.
There's another question here about environment, environmental conditions such as water quality or air. What do we know about the environmental factors relative to getting Alzheimer's or dementia more generally?
Oh, I'm glad someone brought this up. I think this is really important. It's, I think, a newer area of research in Alzheimer's and dementia, but from a public health perspective, thinking about what we can do in the environment to not just treat individuals, but think about making healthier communities is really relevant. So I think there's some evidence that the air pollution exposure to air pollution consistently is associated with, or I guess persistent exposure to air pollution is associated with slightly higher risk of dementia. I think we're still building an evidence base on that. But when we think about policies to promote clean air, that it can promote overall health and then also potentially brain health as well. In terms of water, there's a really interesting study that's been led by some researchers at USC that showed that lead in drinking water early in life might be associated with dementia later in life. And we think that might have to do with the fact that lead can cross the blood-brain barrier in early life and can impact cognitive function that can carry forward to impacting brain health throughout the life course, not just in childhood, but also in older adults as well.
There's a question here about persons who have not been diagnosed with Alzheimer's, but notice a loss of memory, hard time focusing. What would you recommend for someone like that? What should they be doing?
Get a baseline evaluation.
And a baseline evaluation, would that mean basic, like a mini mental test? What does that mean?
So in part, I would say this depends on your age and your complaints. But one of the things that I have to determine when I'm seeing somebody is, have they declined from a previous level? And everybody starts out at different levels. And sometimes it's not easy for me to tell what your score might have been on a test previously, for example, before you came to see me. So I don't know if it's a decline or to what extent it is. What helps me the most, if I'm really unsure about what's going on, and particularly, for example, in highly educated people, where on something like the mini mental, they're likely to do a perfect score, and yet they're still telling me, you know, they've got complaints or they're having trouble concentrating or doing their job or whatever. I get a baseline level so that I can have them, if nothing else, come back a few months later to see if I can detect any additional decline. I also give them more than the mini mental. I mean, this can be done in a brief hour-long thing. It doesn't have to be 8 hours or anything. But I give them, you know, more specific tests of memory, specific tests of executive function, you know, because lots of times you'll be able to detect the problem and see what domain it's involved in. I also approach those patients and try to figure out if they have a treatable cause. So people who are expressing difficulties, whether I measure them or not on a mini mental or whatever I do, I usually check them for things like thyroid function. I check them, try to assess if they're depressed. I look at things that I think I might be able to fix. I mean, one of the 100 causes of dementia, or more than one, is due to vitamin deficiencies, for example, vitamin B12. Or what we call combined systems disease, which is easily treatable with a B12 shot, can cause cognitive problems. So I look for things that I can treat that might be causing the problems, which may not be Alzheimer's disease at all. In fact, the milder they are, the better chance I probably have of detecting one of those things, or putting them on an antidepressant and improving memory scores even that way.
There was a related question coming back to that mild cognitive impairment. Does it always progress to dementia? And if so, what percent would you say stay at mild cognitive impairment and there is no progression? Tough question.
Yeah, it is, because it depends what percent among whom, right? So the original paper that published this, first of all, was made up of people who were worried enough about their memory, and they showed up at a clinic and they got the diagnosis of mild cognitive impairment, and that meant their memory scores were really bad. 1.5 standard deviations generally means if I gave you a list of, for example, 9 words, you're only remembering 0 or 1. Depending on your age group, you know, maybe 2 at most, but it means your memory is really quite bad. Among those individuals, the risk of progression was reported at 12 to 15% per year.
Mm-hmm.
When we looked in a population sample, or other people looked at population samples, what they found was even as much in one population study in Europe, 40% of individuals who appeared to be mild cognitively impaired when they were seen for their study visit, 40% of them a year later were no longer considered MCI, and it actually gotten better, not gotten worse, right? So you can go in either direction with MCI. And if I look in the population, the rates of progression are definitely not 15%, usually not even 12%. I'd say they're often around the 8 or 10% per year. What that means, though, is that 5 years later, you would expect at least half of MCIs to not have progressed in a population sample. So it's really variable. Some people even get better from that state. Some people do go on and get worse. Some people just sit in that state. There's a lot of data to suggest that men in particular seem to sit in the MCI state while women move through it on getting on to the other side. I'm not sure exactly what that means, but that has also been suggested that there might be sex differences about progression from MCI.
So we have time just for a couple more questions. One came in again about our discussion earlier about accelerated approvals for drugs that may not be showing much clinical benefit, but may show on some biomarkers. And the question is about, is that the best use of limited financial resources? Where should we be putting our money? Where should we be putting our efforts?
So can I just clarify? You mean the finances that are used to buy the drug if it's been approved?
Yeah, yeah. Is that the direction we should be moving?
Mhm. So I guess it depends on how much you believe that this drug is, likely to help. The Centers for Medicare, CMS has decided, at least thus far, that they will not pay for that drug, which if they did for the entire population would certainly bankruptcy them in a minute. They've also made the decision not to approve for clinical payment of clinical use of an amyloid PET scan or any of the other biomarker PET scans, at least on the pipeline right now. So at the moment, we're not at least using our healthcare dollars, the ones that go through Medicare, which is mostly what we're talking about for this population. We're actually not using them. Now, that doesn't mean they're not available, and you can pay for them if you want them. Then I guess you're deciding whether or not your own personal dollars are worth it, and probably people have a different ratio for that. I would say we shouldn't bankrupt our entire system for a drug that we don't know is going to make a population level large difference for sure.
Mm-hmm.
So personally, I haven't had too much problem with the decisions that CMS made. I understand their thinking. And I guess whoever asked the question, they're thinking also. Mm-hmm.
Elizabeth Rose, anything to add to that one?
Yeah, I was just going to add that I think that when we think about where our dollars as a society should be going, I think we really want to focus on treatments that we know can improve people's quality of life. And that can include thinking about non-pharmacological treatments that can really help people with dementia and their caregivers have a higher quality of life.
So we have time just for
the cost for anacatamab is more like $100K a year, probably, no matter. I mean, there is the price of the drug, but there also is the price of the infusions, which are at least monthly and have to be done in an infusion center. This is not a pill you take at home. In addition, there's the cost of probably multiple MRIs looking for these brain microhemorrhages, which may or may not be symptomatic, but need to be done on a regular schedule. So the cost for each person is not little.
Yeah, I'm glad you brought up all the additional costs. And yeah, I think we can imagine the additional costs that could go into social workers and other supportive services that we know can actually improve people's lives.
One last question.
Have been well shown to delay intervention in patients with dementia, and that's a study from like 40 years ago. I used to show the slide and say, I bet you guys are all going to ask me why. I mean, when's this drug getting approved? Because I showed the difference in rate of decline by making a social worker available in someone's study, and it reduces a lot of the bad things and the stress and the institutionalization. And I think, it's a wise investment. They're my heroes.
Yeah. One last question came up about COVID-19, and we talked a little bit about the social isolation resulting from the pandemic and how that could play into dementia and Alzheimer's risks. Anything else about COVID-19 and exposures and infections and how that might interact with risks?
Oh my God.
Yeah, I think we still don't know, but I think that there's reason to believe that not only the social impact of the pandemic, but that COVID infection might impact the brain in ways that could put someone at that could influence dementia risk. I think, as Claudia mentioned, that it's a mixing of various different brain pathologies, and maybe a COVID infection could result in brain changes that could kind of tip someone potentially over the edge to result in clinical symptoms. But I think there's still a lot of work to be done to evaluate that.
And I would extend it too and say that all viruses potentially. I mean, there's certainly an entire literature suggesting relationships potentially in some studies, but not all, between other infections, other particularly viral infections, including herpes and mono and things like that. I think COVID has clearly already shown us it can give us a version of what we use, chronic fatigue or something like that. Whether or not it increases your dementia, I don't know. But COVID, one thing I will say, at least COVID is, it doesn't seem to like living in the brain. So you don't find virus generally in the brain. You find some other changes often in people who've had really severe disease, but it doesn't like living in the brain, unlike some viruses which do like living in the brain and causing trouble there.
Great. Well, on that note, I just want to close by thanking both of you, Claudia and Elizabeth Rose. I can't thank you enough for joining us today and sharing your expertise and insight on this very challenging and very, very important public health problem. I just want to remind the audience that a recording of this webinar will be available soon on the Fielding School of Public Health's YouTube channel, so please check it out. I want to thank all of you, the audience, for being a part of our inaugural episode of Our Path Forward. We hope to see you again soon on a future episode of our series. Thank you again for joining, and have a wonderful day.